COVID-19 management for 1 month to 19 years old. When to suspect COVID-19? Symptoms and signs of COVID-19 are non-specific and mimic any viral illness. Fever, headache, myalgia, fatigue, coryza, cough, sore throat, rapid breathing, diarrhea, vomiting, abdominal pain, poor feeding in an infant, loss of taste or smell, rash, conjunctival congestion, mucositis, shock. Asymptomatic but has a close or household contact with a COVID-19 case. Whom to test? Testing is recommended ideally for all the suspect cases to avoid transmission to other members. Prior to any procedure or hospitalization. However, if resources are scarce, then testing may be deferred for both asymptomatic contacts and children with mild symptoms and no comorbidities, and a known positive family member should be isolated. Such children may be presumed to be COVID-19 infected and be managed as per the guidelines. Comorbidities: chronic kidney disease, congenital heart disease, chronic liver disease, neurodisability, morbid obesity, severe malnutrition, current malignancy, immunocompromised state, diabetes. Which tests should be done? So testing should be done as soon as possible after onset of symptoms. Rapid antigen test in nasopharyngeal swabs has low sensitivity, so if negative, RT-PCR should be done. RT-PCR in nasopharyngeal or oropharyngeal swabs has faster results. Children with symptoms suggestive of COVID-19 but negative RT-PCR test should undergo repeat RT-PCR and evaluated for other illnesses. If symptoms are protracted and RT-PCR is negative, CT chest may be done. If no alternative diagnosis, treat as per COVID-19. Classification of disease severity. It also includes the children who have high index of suspicion but their test result is awaited. So mild, moderate, severe. Mild disease has fever, sore throat, rhinorrhea, cough, diarrhea, vomiting, and no fast breathing. Moderate disease has fast breathing, age-based fast breathing, or presence of hypoxia, that is saturation 90 to 94% on room air, and no signs of severe disease. Severe disease has pneumonia with any of these: saturation less than 90%, increased respiratory effort, grunting, severe retractions, lethargy, seizures and somnolence, severe diarrhea, vomiting and abdominal pain. Critical disease. It is a subset of severe disease and it is defined in any of these is present: ARDS, shock, multi-organ dysfunction syndrome and acute thrombosis. Now what is the treatment? Mild disease. It can be managed on OPD basis or home treatment. Hydration should be maintained. Breastfeeding should be done. No antibiotics are required. If fever is there, paracetamol to be given. If nose block, nasal saline drops. Multivitamins may be given. No investigation required. Red flag signs include rapid breathing, saturation less than 95%, persistent fever, lethargy, drowsiness, poor feeding. High-grade fever for more than 3 to 4 days could be due to COVID, but should also be investigated for alternate diagnosis. So CBC, CRP, urine routine, blood culture, X-ray chest should be done. Mild disease with comorbidities. So if ready access to healthcare is available, then we can continue the treatment as per mild disease at home. If no ready access to healthcare, then we can admit for observation and evaluation, and we can manage as per the comorbidities. Now moderate disease. We have to admit in COVID-19 ward. Investigations include CBC, RFT, LFT, CRP, chest X-ray, and may be repeated at 48 to 72 hours as per the clinical condition. If saturation is more than 94%, then we have to give hydration and paracetamol with or without antimicrobials. If saturation is less than 94%, then oxygen, IV steroids, remdesivir, antimicrobials. Severe or critical disease. COVID-19 ICU, HDU or ward should be considered for admission. Investigations include CBC, RFT, LFT, CRP, procalcitonin, D-dimer, ABG, lactate, ECG, chest X-ray, if needed troponin I, echo, ferritin, LDH, and may be repeated at 24 to 48 hours as per clinical condition. We have to give oxygen and if needed HH, FNC, CPAP, NIV or invasive ventilation. Consider prone positioning and restrictive fluids. IV steroids, remdesivir, enoxaparin, antimicrobials. Manage shocks, ARDS, AKI, HLH, myocarditis as per protocol. Remdesivir should be given only in hospital setting. For up to 40 kg, the dose is 5 mg per kg on day 1 and then 2.5 mg per kg from day 2 to day 5. For more than 40 kg, 200 mg on day 1 and 100 mg from day 2 to day 5. Remdesivir to be used within 10 days of onset of symptoms and when child is on oxygen. It is contraindicated if ALT or AST is more than 5 times normal or if creatinine clearance is more than 30 ml per minute. Steroids include 0.15 mg per kg of IV Dexa for 5 to 14 days, and other steroids can be given in special situations. Antimicrobials include IV amoxicillin, Coamoxiclav, ceftriaxone if we suspect any bacterial co-infection. Enoxaparin for less than 2 month age, the dose is 1.5 mg per kg per dose BD. For more than 2 month age, 1 mg per kg per dose BD. So this is all about the management of COVID-19. Please like, comment, share and subscribe. Thank you.